Okay. Well, welcome very much to Kite Rounds. I'm really pleased to introduce our speaker today. I was saying a moment ago that he was supposed to come in person, and then we had a terrible ice storm, and that had to be canceled. So he very graciously rescheduled to this virtual call. And so I'm pleased to introduce Dr. Hamid Azami, who is not very far away. He's just down the street in CAMH. He's a scientific associate there. And he specializes in biomedical signal processing and AI. He has a PhD in biomedical signal processing from the University of Edinburgh. And he did 2 years of postdoctoral research at Harvard University. And so he is here today to talk to us about EEG as a biomarker in cognitive impairment. So welcome very much and take it away. Looking forward to hearing your talk.
Thank you so much for the introduction. And okay, and okay, I just want to share my screen to start my send request. Okay, great.
Great. We can see your slides. They look good. Thanks.
Okay, great. Hi, everyone. This is Hamid Azami. I'm a scientific associate at CAMH, and I'm very happy to talk about EEG as a potential biomarker in cognitive impairments. First of all, the challenge we have in Alzheimer's disease, Alzheimer's disease accounts for around 70% of dementia cases worldwide. AD is usually, preceded by mild cognitive impairment or MCI. Oh, what happened here? Or MCI, typically they are functionally independent, but they have some early symptoms, showing that some cognitive impairments. And the main thing in Alzheimer's disease is finding early biomarker to distinguish mild cognitive impairments, from healthy controls, healthy people, also MCI from people with Alzheimer's disease. And if we are able to detect or distinguish, MCI and in early stage, we are able to have some medicines, some kinds of treatments to hopefully treat Alzheimer's disease. And the thing is especially based on some new treatments we have in the markets. And the thing is that the current gold standard tools, typically we use some cognitive tests such as MoCA and MMSE. There are two main tests that typically we use. Also, we have some established biomarkers. They are based on MRI, PET scan, and CSF. But the problem for MRI, PET scan, and CSF are that typically they are not. They are expensive, and also it is difficult to use them for monitoring. Another reason is that they are not portable as well. In this scenario, we have another thing that typically that is getting more and more common is EEG, and EEG is a device. It is a tool, is a non-invasive, low-cost, portable tool to detect brain dynamics, and it is great for high temporal resolution, and also it can be used for monitoring because of its advantages. But however, traditional EEG analyzers that typically people use power spectrum miss some complex and nonlinear brain dynamics of EEG signals. In this scenario, we discuss some algorithms to be able to detect, that we can use to detect mild cognitive impairments. Okay, and in general for EEG and MEG-based approach for cognitive impairments detection, we have three main approach plus one. And the thing is that the first one is power spectrum. And typically people have a fast Fourier transform of the data. And the thing is that, okay, we check the band power, relative band power of the data, such as delta, theta, alpha, and beta, different frequency bands for EEG signals. And also we check peak alpha frequency and the other things. Also, another type of algorithms are complexity and nonlinear measures. I mean, we usually use entropy and fractal dimension algorithms. And there are a few algorithms in the field, such as dispersion entropy, sample entropy, and fuzzy entropy. These algorithms typically detect different kinds of dynamics in the signal that, in the signal. And for example, typically we can see a significant difference between people, healthy control people and people with uh, cognitive impairments. The complexity typically changes, for these people. And also another main approach that we usually use is connectivity. And we usually check the connection between different parts of brain. And one gold standard for Alzheimer's disease and maybe my cognitive impairment to some extent is that the connection between frontal and occipital lobe in the alpha wave. And there are a number of approaches for functional connectivity. And another thing that we also consider that, we have functional connectivity. And also, if we consider brain as a network, the connection between different parts of brain, and we can also use some mathematical concepts based on graph theory and network analysis to detect Alzheimer's disease. And finally, and nowadays there's a trend to focus more on mathematical part and deep learning part, such as EEG microstates, deep learning approach. Some other, specifically for deep learning approach, we focus on self-supervised pre-training and the other things. And also there is a trend to combine the information, to have multimodal data for that. For example, we have EEG, fMRI data together, or EEG wearable data, such as even heart rate variability, heart rate data, which can be used for sleep EEG and the other things. Multimodal data, based on different things we have, can also be used for detecting cognitive impairment at its earliest stage. Here we have two examples to show that how it works. You can see the healthy controls. Subject with no, cognitive impairments. The thing is that healthy subject, you can see here, this one. And another one as Alzheimer's disease. You can see the data here, the red one. And the thing is that, as I mentioned, if we consider power spectrum of the data, of both of the data, one of them is one for healthy control, and another one is AD. And if you compare that, you can see the information we have is relative power. And if the information we have for Alzheimer's disease is more on lower frequency components, meaning that typically people with Alzheimer's disease has a slower signals. The and more periodic signals compared with someone with Alzheimer's with health and a healthy control subject that you can see here. Again, shifting the frequency, a main peak frequency. Also, you can see the information is more focused on lower frequency components compared with higher frequency components that we have in healthy controls. And we usually consider four main frequency components for Alzheimer's disease, and it is called delta, theta, alpha, and beta. And delta is the frequency component of 1 to 4 hertz, theta 4 to 8 hertz, alpha 8 to 13 hertz, and beta 13 to 30 hertz. And as you can see, the information we have, the relative power we have for Alzheimer's disease, you can see more information, more power here in lower frequency components. And again, lower frequency components, 80 is more. And then higher frequency components, it is more, for healthy control, or, you can see we have higher relative power in these parts. And it is one typical thing that people use, power spectral analysis. And another thing that we usually consider is functional connectivity, the connection between two parts of brain. Here, as I mentioned, typically we take into account frontal and occipital lobe, the connection between frontal and occipital lobe. Here, I showed based on the paper, and the thing is that I showed here healthy control signals. One of them is frontal theta, and another one is occipital theta. And excuse me, occipital late data and frontal data. And for healthy control signals, I use Granger causality as a measure to uh, detect connectivity between two signals. As you can see, imagine, for example, this part and this part, this part and this part, and this part and this part and this one. You can see there is you can see the difference between that is in like that they move together. These two signals move together. The data we get on the frontal lobe is very similar to what we see on the occipital lobe, with uh, only one a little bit delay. But you can see the delay. It repeats itself. And the thing is that, but for Alzheimer's disease, and typically we are not able to see such a movement together. In general, they flow together. For healthy controls, if you record the data in healthy controls on the frontal and occipital lobe, but for example, for someone with Alzheimer's disease, there is no such a connection. And it is another thing that typically people take into account. And okay, I will talk about a couple of studies here, and the main study is based on our PACT MD study, and their lead PIs were Dr. Tariq Raji and Dr. Benoit Moussant. And the thing is that it was a study, double-blind, randomized control trial. We had uh, healthy controls, MDD, uh, remitted major depressive disorder, and also people with MDD, major depressive disorder, plus MCI, and cognitive impairment. And also we had some other subjects from, Alzheimer's disease subjects. And the thing is that, the main thing we wanted to do based on the data set we had to try to distinguish healthy control from MCI and healthy control from RMDD, people with depression plus MCI. And we have some studies based on this data set. And the first study is about beta to theta power ratio. I will talk about that. And then it is about complexity approach, multi-scale dispersion entropy. And finally, we talk about connectivity-based approaches. Okay, this one is theta beta power ratio in EEG. As you can see, as a background, I can't talk about this part. Typically for power spectrum, we consider it is a power spectrum of an EEG signal, and typically we analyze the data based on power spectrum. But nowadays there is a trend to uh, to uh, distinguish or to separate periodic parts of EEG and a periodic part of EEG from the main power spectrum. Imagine it is the power spectrum of the EEG signal. And the thing is that people now, detect first this part of the signal, which is called a periodic component of EEG signal, and from periodic parts. And first, they fit the algorithm, based on that to detect this slope is called a periodic part of the data. And then they get periodic or the real oscillations of EEG signals. And based on that, and it is claimed that the periodic part of EEG signal is related to cognitive impairment, and this part, the slope of the of the power spectral density of the power spectrum of the data is more related to aging and some other disorders. In this scenario, we did the same. And we also, okay, um, we also take into account, four or five main frequency bands, delta, theta, alpha, beta, and gamma. In addition to, for example, as I mentioned previously, that beta is increased in, is decreased in MCI, and uh, uh, theta is increased in MCI. But, and the thing is that based on that, we try to consider the ratio between beta and theta, and beta over theta. The thing is, and in this scenario, we had delta, theta, alpha, beta, gamma, and also the ratio, beta to theta ratio. And the thing is that our hypothesis was that periodic parts of EEG signals or oscillations, real oscillations or rhythms of the signals of EEG signals are more relevant to cognitive impairment compared with full power spectrum of the data. And the thing is that in this scenario, based on the data set we had for healthy control MCI and AD, and we calculated full power spectrum. It was used for many, this full power spectrum has been used for many years. And the thing is that you can see healthy control MCI and AD. As you can check, there is no very clear difference between healthy control and MCI typically. You can see the difference between AD and MCI and healthy control, but there is no difference here. But specifically here, and there is no difference between healthy control and MCI. But if we focus more on periodic components of EEG rather than full power spectrum of EEG, we could find some differences here specifically, and also here between healthy control and MCI. And also a periodic components of EEG, which is related to aging. You can see there is no difference between healthy control, MCI, and AD. And in this scenario, the thing is that in the next step, first we understood that a periodic components unchanged across groups between healthy control, MCI, and AD. Again, it is more related to aging rather than cognitive impairments, that much. And also, I can show you here more. We calculated delta, theta, alpha, beta, gamma, and beta to theta ratio in different brain regions. But after Bonferroni correction, we understood that here is the only part, you can see the difference between healthy control and MCI. And beta to theta ratio, is the only metric that we can use for distinguishing healthy control from MCI, which is the most important thing for us because we want to detect Alzheimer's disease in its earliest stage. And okay, as you mentioned that it is after Bonferroni correction, we have p-value of this and effect size of 0.52. After that, we try to classify the database on periodic oscillations of the data compared with full spectrum data, full power spectrum data. And what we understood that for healthy control versus MCI, the IUC is 0.68 compared with IUC, previously we had 0.060. Okay. And also for healthy control versus AD, we got the best results. The results are interesting, specifically because it is IUCs, and IUC of 0.94 is not typically can be found based on EEG signals. And finally, MCI versus AD, you can see the results. And all of the results based on the real oscillations of EEG signals are much better than, noticeably better than what we found previously. and based on full power spectrum density. And you can see there is a, I mean, we had here 0.94, and we had previously 0.78 as AUC. And another thing we did was we also calculated the correlation between our cognitive test or MoCA with the beta theta power ratio. As you can see, I mean, rho is equal to 0.49 here. And another thing is, but previously we had, I mean, the rho was 0.38. It is based on healthy control, MCI, and AD. If we wanted to have all of the data, healthy control, MDD, MCI plus MDD and AD, I mean, we still have more or less good, I mean, correlation here. And the thing is that, okay, it is another thing that I wanted to talk about. But in general, these studies, I mean, we showed that aperiodic unchanged, and also periodic or real oscillations of the data is the most important part for cognitive impairment, and higher classification, also higher correlation with cognitive performance. The second study I want to talk about is multi-scale dispersion entropy is a complexity measure. I will talk about that, I mean, quickly. In general, I mean, brain is a complex multi-scale system, as you know. And the thing is that, I mean, one thing that typically people use is using, I mean, to define a metric to quantify the complexity of the EEG signals, to understand how complex the data EEG signal is. And I mean, one of the base metric that we usually use is entropy. Entropy quantifies the dynamics of quantifies the uncertainty or irregularity or complexity of the data. And typically people use multi-scale sample entropy, but in 2017, we developed the concept of multi-scale dispersion entropy. And multi-scale dispersion entropy compared with multi-scale sample entropy, which was introduced in 2001, I guess. I mean, is more stable and sensitive to sensitive to dynamics of signals. And multi-scale dispersion entropy is more related to dispersion patterns and Shannon entropy. And we considered two parts of the data. I mean, we consider short time scales and long time scales for the multi-scale entropy. If I want to be more, I mean, clear about that, I mean, the algorithm is based on coarse graining process plus dispersion entropy, but I want to talk about it in this way as well, because it is the main concept here. Imagine it is the original EEG signal we have. I mean, at scale 1, it is original signal. It shows local information more. It is lower, I mean, it includes higher and lower frequency components. And it includes local information of the data. You can see we can't find any short change here as well. But if we go to higher scale factors, we show the global information of the data. As you can see here, if you compare this one with this one, you can see still compared with that one in this one, and you can see we get global information of this signal, but not local and short change in the signal. I mean, the main part of multi-scale dispersion entropy is dividing, the original signal from, local information to global information. We try to analyze the data in both local and global information. And in this scenario, both of them are important. This part, local, and this part is global information. And also we wanted to understand that for Alzheimer's disease, which part is more important, local information or global information? And okay, in short time scales, 24 milliseconds, it's more or less local information. We showed that Healthy control, people, I mean, normal people, and this thing is the norm, healthy people, and this thing, I mean, in terms of complexity, is very similar to RMDD. I mean, people with remitted major depressive disorder, but the complexity will decrease from healthy control to MCI and from MCI to Alzheimer's disease, meaning that local information, also for example, RMDD, uh, RMDD didn't play the main role, but cognitive impairment led to lower complexity values in local information, more local information. And you can see the effect size here and p-values here. And also, I mean, very similar to that. But the thing is that there is no difference between healthy control and RMDD didn't remitted major depressive disorder doesn't affect EEG signals. And also, we also check the long time scale. I mean, it is more global information of the data. And we understood that there is no significant difference between healthy control, MCI, and RMDD plus MCI, but there is a significant difference between these four groups and Alzheimer's disease, and showing that global information of EEG signals is, I mean, not that much important in AD stage of Alzheimer's disease. It affects more that, but local information plays a main role in mild cognitive impairment, as I showed before. As I mean, as the thing is that we also compared multi-scale dispersion entropy and multi-scale sample entropy, which was, I mean, as a as the first metric for complexity. And we showed that multi-scale dispersion entropy, I mean, in terms of effect size and significant difference, is better than multi-scale entropy. And then we also, like the previous study, we checked the correlation uh, between cognitive score that MOCA we have here, also and 20 and multi-scale entropy at local information based on multi-scale dispersion entropy. And R squared was 0.63, which looks good. And also based on this data, I mean, all of the data, we got these results as well. Okay, in general, what we found that based on complexity is that people with in shorter scale, multi-scale dispersion entropy or complexity measure, I mean, people with, I mean, people with normal cognitive score, I mean, their EEG signals look, I mean, more complex. And after that, if we go to people with mild cognitive impairment, the EEG signals becomes less and less complex. And after that, we have for Alzheimer's disease that the data recorded from someone with Alzheimer's disease is the least complex, meaning that the least information in general the data has. And RMDD, I mean, remitted major depressive disorder, doesn't affect, which is a risk factor for Alzheimer's disease, which didn't affect complexity of the data, of the EEG signals. And I mean, here also it shows that global information or global network of the data doesn't affect that much, I mean, in mild cognitive impairment, but only in AD you can see a difference in higher scale factors. And the third study I want to talk about is three-order interactions in alpha band default mode network EEG based on O information rates. I mean, and one thing, first of all, I want to talk about, I mean, connectivity. I mean, typically for connectivity approach, we have one signal here and another signal here, for example, one signal in frontal lobe and another signal in temporal lobe, and we try to check that the connection between these two parts based on, for example, we can use mutual information and to check that how they move together. I mean, how they are connected. And the thing is that the information, the shared information between these two signals, it shows, I mean, the connectivity between those. But I mean, it is also called two-order interactions or second-order interactions. The connection between two parts are two nodes or two variables. But in general, nowadays people also check three-order interaction. In three-order interactions, we also check. I mean, imagine we have two people talk together here, two people talk together here, and two people talk together. But in two-order interactions, we only consider two people or two variables. But in three-order interactions, we consider the interaction between three people at the same time. I mean, the time between this and this and this and this and this and this part and this part and this part. I mean, the time is different. But the thing is that here we check the interaction between three parts or three people or three parts of brain together. Okay, in this, the main part of this one is this, and here it is the main part of higher order interactions. And based on that, typically we define two important things. The first part is redundancy of the data. Imagine how much info, I mean, imagine we have three parts of brain. I mean, we want to understand, I mean, how much information are shared between these three parts. Okay, the overlap between these three parts of brain. And also, another thing that is interesting is that based on three-order interactions, we are able to check the synergistic information. And in this scenario, we want to understand if three parts of brain work together. I mean, we want to understand that how much information they can create together if they work together. Three parts of brain uh, I mean, work together, how much new information we have, or um, information, I mean, emergency of new information. If I want to go, I mean, it is the base, I mean, the base of higher order interactions, redundancy of the information between three parts of brain and how much new information they can create if they work together. All of the three nodes are active or connected. In this scenario, I mean, typically people use mutual information and showing that the shared information between two signals, but we have here mutual information rate, which is more or less the same as mutual information, but the difference is that we check the information flow over time. I mean, it is shared information per time. I mean, the only difference between mutual information and mutual information is that. And O information, which is three-order interactions, is the extension of mutual information, but O information rate is the extension of mutual information rate. In fact, in we check the redundancy of three parts of brain and synergetic, I mean, information between three parts of brain and during time. Okay, imagine we have, for example, I mean, for this study, we had again healthy control, MCI, and Alzheimer's disease. And the thing is that we checked default mode network. Default mode network is a network on frontal, temporal, and occipital lobe, parietal lobe. And the thing is that we wanted to understand, I mean, how much information is, I mean, redundant between these three, and also how much information they can show if they work together. And in this scenario, I mean, the focus was alpha wave because, I mean, based on the literature, alpha wave plays a main role in aging and Alzheimer's disease. And we have two data sets. One is, 95 younger versus 93 elderly subjects. And also we had another data set 44 healthy controls, 84 amnestic MCI, and 41 AD. Okay, we showed that for healthy control and aging, in healthy aging, young versus elderly, uh, both are healthy. And the thing is that in three-order interactions, we can see a decrease in OIR. And also, we see a decrease in redundancy. But there is no difference between young versus old people. But one interesting thing here we can talk about is we can see a redundancy between young and elderly, from young to elderly subjects. And it means that, imagine there is no connection between these three parts of brain. For example, for young subjects, because the connections are more. And in this scenario, the we do not have loss of connection that much. The information we get in the frontal, temporal, and occipital lobe together are more, shared. They have more information together. But compared with elderly subjects. But for both of them, there is no difference between, I mean, there is no difference between young and old subjects in terms of creating new information or synergetic information. Now, again, for healthy control versus amnestic MCI versus AD, also there is no difference. After one-for-one correction, there is no difference between healthy control and amnestic. Is that we expect that because for Alzheimer's disease, we have because for Alzheimer's disease, the connection is lost. The connection between different parts of brain is missed. Redundant information will decrease as well. Here, it is related to OIR as well. And you can see here the p-value and also effect size of the data here as well. And we also check the classification between these three groups, between these two groups and these three groups. And for young versus elderly, the IUCs here is equal to 0.75 based on OIR. But also we have MIR, two-order interactions, basic connection between two parts of brain. And it was 75, this one is 74. And if we combine the information in three-order interactions with two-order interactions, the AUC increases noticeably here from 0.75 to 0.81 for healthy control versus AD. And also we can see such a pattern in healthy control versus AD. If it is three-order interactions, is a new approach, but this one is previously we use only the interaction between two parts of brain. Here it is based on three parts of brain, the interaction between three orders. And the thing is that for three-order interactions, if we combine the interaction between any two pairs of brain to any three parts of brain, we can get even IUC of 1 that is okay, perfect. And the thing is that for this one, we can see such a thing as well, the pattern as well. And also here, like before, we check the correlation between cognitive performance, quantified by MoCA, and redundancy in OIR. And we got these results, showing that there's a good correlation, R square is 0.28. And in general, here we showed that, I mean, it is good in general, but we suggested that three order interactions might be a good thing to, to our analyzers or to discriminate healthy control from Alzheimer's disease and MCI from Alzheimer's disease. And as a new trend, and we can consider both connectivity and three-order interactions together and having higher classification values, also having higher uh, correlation. And in general, I mean, EEG biomarker comparison, all three studies can be found here. And the focus more on that, this one for RC control versus MCI was probably the best. And also, I mean, periodic part was, the results for RC control versus MCI, you can see the results here. And, and cognition, where the correlation between these potential biomarkers and MoCA, cognitive performance. And also we have recently, introduced three mathematical concepts, called segregation, integration, and complexity based on some graph theory and the other things. It is just for information. And finally, for future research direction, I mean, we, I mean, I, I'm, it is good people focusing on some more advanced algorithms in the field, such as, for example, instead of multi-scale entropy, we use people focus more on multivariate multi-scale entropy, because in multivariate multi-scale entropy, we take into account the spatial domain in addition to time domain. But also, it is one thing that people can use. Also, new complexity measures such as fuzzy entropy, fuzzy dispersion entropy, or ensemble entropy. And also, we can consider, we can improve the algorithm periodic versus aperiodic components for distinguishing periodic EEG for Alzheimer's disease. And also, higher order interactions can be, new algorithms in higher order interaction can be developed. And here more about, we have some, causality, the cause, rather than considering uh, the correlation, maybe it might be good to focus more on causal approach. In this scenario, we want to understand that the real, for example, this part, for example, MRI, for example, lesion causes, for example, causes functional connectivity, for example. The effect of, for example, MRI or structural brain on functional part of brain, brain activity or something along those lines. And also there is, it is good to add, to use some data fusion approach for multimodal data, such as EEG, fMRI, FNIRS, and the other things. And I just want to thank you, my collaborators and my mentors and my colleagues. And thank you so much for your attention.
Thank you very much. That's very interesting. It's a lot of work, a lot of data over lots of years.
Thank you so much.
I'm gonna let people get their questions going. I have a question actually to start off with. You didn't talk a lot about how the data was collected, and I wonder about under what conditions was this EEG data collected, and is there an optimal way in terms of collecting it? Like, are you giving them cognitive tasks to do while you're collecting it? Is it resting? What's the best way of doing that?
And the thing is, thank you for the question. This is it is a very important question in the field. The thing is that typically people, the data of all of my data was eyes closed resting state EEG for 5 or 10 minutes at most.
Yeah.
And the thing is that, but our group, as you know, working on N-back tests as well. I mean, theta gamma coupling based on N-back EEG data, and they got very great results. I mean, based on their the N-back test and EEG signals. But my results are very based on only eyes closed each.
And so which is the better way of doing it, do you think? Is it better to collect EEG data when they're working or when they're resting?
I'm not sure. I mean, the thing is that we plan to combine them to see what we haven't compared them. I mean, which is better, but okay, yeah, exactly. We plan to combine them to understand that which of them is better, and also which of them, I mean, is which of them is better even in prediction of cognitive impairment in a couple of years. I mean, based on the PACT-MD data set we have.
If anyone has any questions, please like put your hand up or unmute yourself and jump in. I wanted to, you may have just alluded to this actually, and I wanted to ask you about this about longitudinal data. So all of
Exactly.
this was cross-sectional, where you just had
Yes.
everyone had one set of data. And so what do you think the prospect is that you would be able to detect transitions within a person over time
Mhm.
using these signals?
And the thing is that, I mean, I do not work that much on the data now, but the thing is that uh, one of our group members is working on that. I mean, and she got some results based on resting state EEG, and they found that uh, periodic components of EEG can play a main role. I mean, if we check, for example, the first year data, we are able to even understand what will happen in a couple of years. And the thing is that in that, hey, this is the case.
So someone in your lab has looked at the
Yeah,
longitudinal
yeah,
data and they're okay.
not the first. Okay, I'm not the person who working on that, but
Yeah.
another person found.
Um, does anyone else have any questions? I don't want to monopolize. Um, I wanted to ask about so you did the sort of the AUCs, you looked at the curves. The one that still seems to be the hardest is the one that you were the most interested in, which is healthy control to MCI. That seems to
Exactly.
be the hardest. And
Exactly.
why do you think that is, and how are you going to improve that so that it could actually be useful?
I think it might be good to have EEG signals. I mean, even for example, N-back EEG, to combine some data together, EEG, N-back, and fMRI data, all of them together, it might be one thing. But theoretically, honestly, I'm, I'm not sure how I can improve it. I mean, the thing is that it is theoretically, I probably cannot, but if I want to add new tools, new data, it might be a good thing to improve the IUC, because the IUC is 0.7 for healthy control versus MCI, the best method we had. And might not be very good, but we try to add more data, I mean, new data based on.
You know so of course you do have longitudinal data on this cohort, right? Because you guys followed them for several
Exactly.
years. Yeah.
Yes.
Um, have you ever thought about doing the analysis? So we know that MCI, some people with MCI convert to dementia, and some people with MCI don't convert to dementia. Um, but I guess you guys maybe haven't followed them long enough. You probably would have to be able to follow them for 5 to 10 years to know what proportion of those people converted to dementia. But it would be interesting even to look within the MCI group and separate them out, those people who converted dementia and those people who didn't, because maybe the signal would be stronger in those people who commit and converted to dementia. Yeah.
For your note, I noted here for myself.
Yeah. Um, any other questions from the group? Um, Well, great. Thank you so much for coming and
So much.
speaking
Thank you for
today
the
about your
invitation.
work. We've recorded it, and so I know people who weren't able to come today certainly will listen in. EEG is an interesting modality and one that I think hopefully people are considering and using in their work, and so maybe they've learned a little bit from you about how to assess cognition with it. So thank you again very much.
Thank you so much. Thank you for inviting me. Have a
Okay.
nice
Bye-bye.